All right. So thank you very much for coming in. Cheryl, Sherry, and Megan are here with us, and the rest of the people will join in, I'm sure, or they will watch it later. Um, Obviously, this has become our first meeting because last week, something happened and we could not really communicate in the same room. But I recorded a bit of what I wanted to do in that tutorial. It was very monologue. It was only me talking, so there wasn't much question answers. But I hope that you watched that one and are a little bit more clear about what is required and what is to be done. Right. So first of all, I would say that I am inheriting this unit. This is classically Michel Fennett's unit. If you've done your upper body, or if you've done it last year, it was Michelle who was doing it. But this year, she wanted to concentrate more on her PhD. So we gave her a time, and it landed in my lap. As you know, I'm a radiologist basically, and also a sonographer. So, and I do a lot of MSK. MSK is my sort of, my real interest. My most work is on MRI, but I do a lot of ultrasounds as well. So, yeah, I'm not really very good with ops or, with pediatrics and whatnot, but MSK is really my field. And especially interventions. I do a lot of MSK interventions using ultrasound, CT, even on MR. But unfortunately, I am leaving another 1.5 weeks. So this will be my last Zoom tutorial that I will be doing. There is Kate, who's that? Kate Bradley, who will be, no, sorry, not Kate Bradley. I'm sorry. Who's coming in my place? Anyway, you will get to know in a few days who will be replacing me. But whoever it is, it's not that the unit is not going to change. Maybe that person might add a few a few of their own lectures or talks or some reading material, but what is there on the Moodle site at the moment will remain there. And your assessment items will not change even by a single dot. So you don't have to worry that you might have to feel some change due to change in the lecturer. It wouldn't happen like that. So all the best for the next person, and all the best for you guys going forward. Now, the main sort of study in postgrad level is we are here to mentor you or to help you learn, but we are not going to hold your finger and or teach you in any way. At postgrad level, I understand that you are sonographers with many years of experience. Some may be just starting off, some may be years and years, some may be doing a lot of MSK, some may not be doing. And of course, you are interested in learning MSK, so you that's why you are taking this unit. So we are here to sort of give you direction mentor you, discuss things with you, and give you some basic reading material so that you can um, gain from that and have a structured learning, because you can learn MSK even without doing a master's or doing this unit. Basically, you have a lot of patients, you read up, you experiment, and you learn. And from feedback, from discussing with other sonographers or whatever. But a university course or a university unit gives you a structured learning with outcomes which are tested. So it definitely helps you a lot in learning or brushing up your expertise. Now, having said that, how we do that? Now, there are topics. This will cover the whole of the lower body. We have not divided into lower limb or upper limb because then the trunk gets, it doesn't get covered. So basically, we are talking about lower body, which is abdominal muscles, groin, and back muscles, and then obviously the thigh muscles, knee, the leg muscles, ankle, and foot, including not just the muscles but ligaments, tendons, joints, and all those sort of things. So it's pretty large area to cover. And for that, we have lectures. They are mostly by Michelle, and a couple of other people have contributed to it as well. And they are like really very well known in Australia. Like Daniel Walkley is one of the gurus in ultrasound. He's a physiotherapist basically. So he deals only with MSK. He doesn't do anything else. And on top of that, he did his VMU, and he's a sonographer. So he brings to this unit a very precise clinical knowledge. So you would definitely enjoy that. And then we have Sean McPeak. And Sean McPeak is a very well-known MSK sonographer in Australia as well. So there are lectures, and then there are reading materials. There would be a bit of a guided, very targeted reading materials for you to study. But the main thing is the book. I think Bianchi book is one of the best MSK books ever written, I would say. From a radiologist point of view, obviously it's very different, because we in radiology have very different MSK books, which are mostly based on MRI and X-rays rather than ultrasound. But from a sonographer's point of view, Bianchi book is probably one of the best books. So if you can, in these 12 weeks, go through that book, I think that would be a really good benefit to you. And we have sort of scheduled it according to the chapters of Bianchi. So that, like, for example, in groin, it's a chapter 12 of the book. This is one very bad moth. Sorry about that. And same is with hip gluteal region. Then you go to hamstrings, which is chapter 13, and so on and so forth. So usually, basically, the basic is from chapter 1 to 5, and the specialized lower, the upper limb is from chapter 6 to 11. And then the lower body or the lower limb starts from chapter 12 and goes on to the end of the book, chapter 18 or whatnot. There are a bit of interventional techniques as well at the end. So you will benefit from it. Okay, so that is basically about what is in this unit and what you need to do with that. There are two assessment items. One is an e-poster, and some of you have very good ideas. I have, in fact, put two examples of e-posters from previous years under the assessment item in discussion groups and Zoom tutorial tab. So that is the first tab, in fact, after the welcome and general sort of intro. The first tab is assessment item. And in that one, the first is a video by me about unpacking the assessment items. Then we have a column for e-poster. It gives you all the information you need. There is a link to Vancouver style referencing. If you're new to Vancouver, you need to read that. I am a bit very particular about referencing because sometimes people use, e-medicine or Radiopedia or online resources as their references, which are not peer-reviewed. So, I mean, I'm not doubting their validity. Of course, those sites are contributed by very famous and very renowned sonographers and radiologists, but they're not peer-reviewed, which means that whatever they say is their opinion, and it has not gone through a process in which other people would vet that. So that is why peer-reviewed references are a must. If you use the images from whatever source, that is perfectly fine. You can put a reference that this image was taken from Radiopedia or Ultrasoundpedia or ultrasoundcases.com or wherever. But as a reference, you should not use what they are saying. Your references should be from peer-reviewed journal papers. And they have to be in Vancouver style. So be aware of that. And then we have marking rubric. That basically tells you how we would examine it or score it. And then under that, there are two examples from last year. I have taken the student's name out as much as I can. And both of them scored high distinction HD, which is more than 85% marks. So that would give you a general idea that how to construct a e-poster. Like they say, a picture can, is better than 1,000 words. So I can put a lot of description on what is you need, what the rubric is, blah, blah, blah. But if I show you just one of the e-posters from before and tell you that, okay, this is something which scored high. It doesn't mean that you have to stick to that, but it gives you an idea that what is a good poster and what are the requirements of that. And then you have an online test, which is at the end in October, mid-October, and that is basically a descriptive sort of answers. So you have to take it on the computer, and there are short answers or long answers. Probably a couple of MCQs, but not that many. Basically, you have to sort of write something about that. So yeah, so that is basically your assessment items. Because I know many students basically where they jump to the assessments, they see the assessments, okay, we can do that, and they forget about learning the whole of the rest of the unit. Obviously, we have to, give you a grade depending on how you perform, and your assessments are the most important thing for success. but it is also at the postgrad level. Learning is as important as passing or having a pass mark and then forgetting about it. I hope that you realize that by now. Right, okay. Any questions you might have regarding the unit, assessment items, or anything at all? If you don't have a mic, you can always use the chat option. Okay, all good. If nobody has a question, we can move on. All right. So let's talk about the case of the week. Now, these are formative cases. Then I have intentionally not put them on as a quiz because what I do in my pediatrics unit is that I put up a case, let people discuss it, then put a 4 or 5 simple questions saying what they have understood about it, and then post the correct answers. But this one, I have, and what I've noted in that is that people don't really take the quizzes. They look at the cases, they keep thinking about that, and then when the diagnosis is revealed, they just go, yep, okay, and then they read about that, maybe, go through that paper or whatnot, and leave it to that. So I have not put it as a quiz. It's a case. I post the case, keep it there for a week, and then by Friday I give the diagnosis and some reading material with that. So at least in every region, you will have something to challenge you in thinking about things, and learn at least one abnormality or pathology or anomaly or something which is common in that area. So because the first week was the introduction and revision of basic concepts, which was, what you should know. So I have put a mass or a tumor, subcutaneous tumor, which can be found anywhere in the body, and it's basically an exercise in the basics of of any mass anywhere in the body, which is obviously musculoskeletal. It comes under superficial structures or musculoskeletal mass. Now this, there were 2 images, in fact 3 images there. The first image was, let me share my screen with you, then you can be a little bit better in discussing it. Okay. Now, can you see my screen? Yes? No? Wake up!
Yes, we can see it.
Okay, thank you, Sherry. Okay, so the first image, sorry, it's a bit of small because I have everything zoomed up. Anyway, so the first image is a B mode long image of a subcutaneous mass. Why subcutaneous? Because you can see this very thin layer of skin, and then immediately under the skin there is this mass, and then there is all this fat and everything below that. Okay, fat planes you can see under that. And there is this round, very well defined, it has a kind of thickish capsule around it, a mass which is lobulated and heterogeneous inside. Looks like it's made up of multiple small these mass kind of things. Okay, and there are some areas which are causing a little bit of shadow. Here, something here as well. So it's sort of like it's weeping, right? So there is some acoustic shadowing going on, which would make me think that either it is very fibrous or there is some calcification, right? Okay, so what it can be? A million things. If you give me this image and tell me, okay, doctor, this is the image, can you write a report? I'll be like, okay, it can be a million things. And very rightly, it was treated as a sebaceous cyst by the GP for a long time. Basically, it was a 4-year-old boy, and when he was 6 months old, they took him for a haircut, they cut the hair, and there was this little kind of reddish color on his occipital region, left side, around here. And the barber who was cutting the hair, he said, oh, look, there's something here, and then I can feel something. So mom was like, oh, okay, I don't know what it is. And she brought him to her GP. And GP said, oh, don't worry, scalp, lots of hair. It could just be a sebaceous cyst. Very, very, very common place for sebaceous cysts. You know what a sebaceous cyst is. It's a accumulation of sebaceous secretions in a sebaceous gland due to blockade of its duct. And sebaceous, there are two types of glands. There are sweat glands and sebaceous glands in the body, under the skin. So, and probably he might have sent him for an ultrasound, and they probably just did a B mode, 6-month-old kid, not having any issues with it. It's not tender, it's not painful. And in the scalp, probably, just did a B mode and sent it back, and they said, okay, maybe it's just a sebaceous cyst. A sebaceous cyst looks very similar to this. Not exactly like this, but very similar to this. If you've done your, ultrasound, MSK ultrasounds, and seen sebaceous cysts, most of them, when you see them, they are like that. But then it started to grow. It started to grow rapidly, and it became almost twice the size. And it was not going away, and it was firm, and it sort of was seen as a lump there. And he was sent for ultrasound after 6 months after that, which is at the age of about 1 year, and they did a proper complete ultrasound, and then they followed it up in the last 2 years. It has slightly reduced in size since before, maybe become half of what it was, but it has not gone away. Okay, so you put the Doppler on. Remember, never, ever, ever do just a B mode on any swelling. You must put your color on that. If a sonographer does B mode only on a mass, that's not right. You must put your color on it. And look what the color says. If this was sebaceous cyst, this color wouldn't be there in there. Okay, and very like tortuous vessels. There's this big vessel that is coming in, and they were saying, okay, let's put our pulse wave on that, and spectral Doppler, and they saw this arterial low resistance flow going on with a velocity of about 62 centimeters per second, which means that this is a big artery that is going in there, dilated, supplying this thing. but it can be, it is a hemangioma. Okay, full stop. So if as a sonographer, you get this and on your worksheet you say, okay, this mass is a hemangioma with a big, large arterial feed coming in. Okay, you're an average sonographer. You have done your job, what is required of you. But you have to go further. Hemangiomas are, or vascular tumors, they have a big importance these days. Why? Number one, they are obviously something very interesting, and people didn't really care for them before, but now they are. Second, they can cause death. How? If this is a 6-month-old baby with this big arterial inflow and even a bigger venous outflow, this would act as a fistula, and that would cause a high output cardiac failure in that child. And if he would not die, at least he would have a big morbidity due to a cardiac abnormality. And so 2 things. And the third thing is that these AV malformations or hemangiomas can be associated with other syndromes like Creutzfeldt-Jakob syndrome, or there are lots and lots of syndromes which have got Creutzfeldt-Jakob syndrome, and all those ones can present with a hemangioma, and hemangiomas are a part of that. And if you have one hemangioma, you can have other hemangiomas in the body as well, mostly in the liver. The most common focal lesion in pediatrics in liver are hemangiomas, right? So this is a hemangioma, and what type it is. Now, it was present at birth, so it is congenital or infantile, or we just call that an infantile hemangioma. And what is an infantile hemangioma? They have a very particular history, very specific history. So the history basically is the diagnosis, not these images. You can do a MRI. It will be very hyperintense on T2, iso-intense on T1, and after gadolinium, there will be peripheral enhancement, which will sort of fill in as time goes by. So that is very typical of them. But then that is not sufficient. You have to know what type of infantile hemangioma it is, and what to do with that. So as a sonographer, probably your job is to make sure that you have a hemangioma. It is an arterial malformation. It's an arterial hemangioma, but when you consider your history, then you can say that almost 90% of hemangiomas resolve or involute by the age of 6 years. So you don't have to do anything with this, unless there is cardiac failure going on. Then obviously you have to embolize it. You put a catheter, you embolize the artery, and that's it. You don't have to take it out. You basically just embolize the artery. The other thing you can do with the hemangiomas is to cauterize them. Basically, you just put a cautery, burn the artery out so that the blood flow in is reduced and the cardiac failure is improved. But with this one, you don't have to. The most common one is called a RICH, R-I-C-H. That is called a rapidly involuting congenital hemangioma, RICH. Okay, they are the most common ones, and this looks like that because it was discovered at 6 months of age. It rapidly increased in size initially, and then it has become smaller and smaller. So there is this age curve which peaks at about 1 year, and then it goes down. The size of the lesion involutes comes down by the age of 2 or 3 years, and then it plateaus. It doesn't change for 3-4 years, and by 6 years it just goes away. So that is called a rapidly involuting congenital hemangioma, or RICH. The other one is called a NICH, N-I-C-H, that is a non-involuting congenital hemangioma, and those ones don't change after the initial, in the first 2 years, and then they remain the same for the rest of their life. And they would be there. Often you see adults come in with a hemangioma, fine, they're there, they're not involuting, but they're not progressing or not doing anything. So they're just sitting there. Or then we have what is called a PICH, P-I-C-H, partially involuting congenital hemangiomas. Which are, in between these two. They fluctuate. They have areas of increase, then they dormant, then they increase, then they're dormant, and whatnot. Okay, so that was about the first case. So don't stop at B mode, never do that. You cannot say that, okay, there's a subcutaneous, heterogeneous, well-defined mass with lobulated, heterogeneous internal pattern, measuring 4.3 into 1.5 centimeter, and then obviously transverse, and that's it. Wash your hands and go away. No, put a Doppler and you say that there is irregular blood vessels and perfusion seen throughout the inside of the mass, with a large dilated artery with high flow, and you can see the high flow because of all this aliasing going on in there. High flow and the velocity of 62 centimeter per second, arterial low resistance flow. It will be low resistance because the rapidly comes in, there's a big vein waiting for it, the flow rapidly goes out as well. So it would be a very low resistance flow. If this becomes high resistance, that would mean that there is thrombosis inside, or the blood vessels are being blocked by something, which happens. If I would scan this maybe in 5 years' time, this would probably change to a high resistance blood flow. Because it is involuting. It is either partial involuting or rapidly involuting. And involution is that the blood flow is being cut off. Okay, any questions regarding this case? It was a bit interesting, unusual, but believe me, infantile hemangiomas are the most common arteriovenous malformations or congenital vascular malformations in children. So if you would have this and without using your brain, just say, oh, this is a infantile hemangioma, you will be correct 80% of the times. So yeah, so this was the first case. Okay, let's talk a little bit about the second case. Interesting one. 33-year-old woman, she had a baby. She had 3 cesarean sections done before. And after the 3rd cesarean section, 4 months after that, she detected a little bit of mass in the right side. of the tummy in front, in the pelvic region. And this mass was not present at the time of C-section. They cut it, there was no hematoma or anything formation there, but then it started to grow. And then in the last 4 months, it has really, really grown into a big mass here. And, she came with that to her GP, and the GP palpated, and it was like an egg sized or a tennis ball sized mass sitting there, very firm, if not hard. And you could move it up and down, you can move the skin over it, but it was fixed to the abdominal wall. It was fixed to the abdominal muscles. It was not tender, and there was no pain. The patient didn't have any pain or whatnot. It just was a mass, and she was concerned. So they did an ultrasound. Sonographer was like, okay, I don't know what it is. It's something there. They did an MRI, and then operated and had this thing out. This ball come out, they sectioned it. It had this grayish, yellowish, very homogeneous sort of texture with no internal blood vessels or bleeding inside going on. Okay, so we are sonographers. We will look at this. So we obviously we measured it. It was 5 into 6 into 4 centimeter in size, maybe about 20-25 mil cc in volume, and this was the giveaway picture. You see this rectus sheath coming in, and this is actually growing in the rectus sheath. It is inside the rectus sheath. You see it being interrupted here. So that was in the rectus sheath. And here also you can see what we in radiology call a beak sign, that it is inside the rectus sheath. All the intestines and everything inside the pelvis are perfectly fine. This is contrast in the intestines. On here, very homogeneous, a little bit of some small areas of inhomogeneity, but mostly homogeneous. The blood vessels are displayed away from it. There's nothing much inside. Probably there's maybe an artifact or a small blood vessel where that is going in there, but it's not a highly vascular tumor like this was. This was a vascular tumor. This is not. This is not a vascular tumor. So it's not a vascular malformation. It, post-operatively, what can happen? You can develop AV fistulas, because when you cut the arteries in the veins, when you stitch it up, those can form connections, and then you get an arteriovenous fistula. That is very common after surgery or after trauma of any kind. People are treated, go back, come back after a year or two with a mass which is highly vascular AV malformation. So this is not a it's not a vascular tumor. Okay, and on CT also very homogeneous. It's grayish, almost the same as the muscle, but a little bit less dense there. This one also a little bit hypoechoic than the normal muscle, and it doesn't have any striations like the normal muscle have. MRI, T2 weighted images, high on T2. This is the uterus sitting very separate from it. Intestine very separate from it, and you can see the beak sign here, which means that it is from the abdominal wall. Okay, took it out, big tumor, cut it, very nice, fleshy, fibrous tissue. What is it? Nothing else but desmoid tumor. Nothing else but desmoid tumor. What is a desmoid? It is a fibroma. It is a benign tumor, but it acts malignantly, which means that it does not have the characteristics which would make it malignant. It does not have hyperchromatosis. It does not have abnormal mutations in there. It does not have chromatin network. It does not have the tumor markers on it. Nothing of that sort. So it's totally benign, but it metastasizes. Okay, it grows, it metastasizes, and one tumor can lead to another, lead to another, lead to another. So it has to be removed. Okay, so this is basically a myoma or a fibroma or a fibromyoma. There are many types of desmoid tumors. Okay. It is called desmoid because it has desmoplastic reaction. Okay, I don't know how strong your pathology is, but if you're interested in knowing, this is a very good paper about desmoid tumor. You know, and this is very particular in that one particular case. It was a different case, a smaller tumor in the rectus abdominis, but still exactly the same. And you can see that all these are elongated cells of myofibroblasts. So it's a myofibroma, in other words. So yeah, so this is something very interesting. Not very, how do I say, not very common. But fibromas are common, especially myofibromas. You see them in the muscle, you see them along the tendons, you see them in the in various places, especially you know, in toes or long tendons. You can see them, and they can usually they are a reactive fibrous cells, which means that they can come from, let's say, synovial membranes. They can come from tendon sheaths. They can come from muscles themselves. So whenever you see a non-vascular tumor associated with muscles, think of desmoid. And if you say desmoid tumor, you're more than 85% of the times you're correct, because more than 85% of something similar would be a desmoid tumor. Okay, and the last one I have not, oops, okay, I'll just hide the diagnosis there. I'll put it, the diagnosis on Friday. But there's another one, the last of the this week's case, 3, a 5-year-old baby girl. Okay, now whatever is written here is not to dodge you or confuse you, or okay, whatever, you know, what does history mean? It doesn't really matter. It matters. Every word of it matters. It points you in a certain direction. Okay, so it's a 5-year-old baby girl presented with severe pain in the right groin with a swelling. So she came to ED, and mom was carrying her, you know, and she was like just horrible pain. The mom said that she had this intermittent swelling, which comes and goes for the last 2 years. When the baby cried, it became prominent. Or when she was you know, having exercise, running around, had a long day in playground, you know, this will come out. There would be swelling, but then when she lie down, she would say, okay, you know, this is too late. I will take her to the doctor's tomorrow. And the baby goes to bed. Next morning, there is no swelling. So mom says, if there's no swelling, what are they going to show the doctor? And maybe they went to the doctor a couple of times. There was nothing there. So it was like, okay, don't worry. He's just, there's something that comes out. And this swelling used to come and go. But then for the last one day, she probably had a bout of coughing, or she was playing a lot, or whatever she was doing. This swelling came up, and this time it was very, very, very painful. And the kid was just inconsolable. And for the last one day, it has not subsided at all. In fact, it has become bigger and bigger. So, you have the patient, you put them on the ultrasound bed, and you go doing the examination. Now, how many of you as sonographers listen to the patient and put your hand on them to examine rather than lie them down, put the probe right on? Hardly any, I think, because obviously, you're doing 20, 25 patients. Some of the sonographers I've seen do 35, 40 a day as well when they have this, bonus depending on how many patients they can do. So don't be those type of sonographers. Quality is a lot better than quantity. But as a habit, as the sonographers, we are not really trained to examine the patients. But believe me, if you develop a bit of clinical examination processes, which you can easily learn by studying the clinical examination books, or if you have a doctor friend, you can just there are so many things. You just put the hand on there, and half the diagnosis is there. I always say your imaging is a confirmation or a ruling out of your clinical diagnosis. Once you do your clinical diagnosis, you're 90% there. You do your imaging just to confirm that, okay, this is what I'm thinking. Is it really that? Or get surprised, oh, okay, no, they say it is something else. Okay, I go back and join the dots, and maybe I was not clinically correct. So clinical diagnosis is a lot important than your ultrasound or your CT or whatever. So when they did the exam, there was an egg-shaped swelling in the right medial groin, almost at the labia, overlying the labia. And it was non-reducible. They tried to squeeze it back up, but couldn't. And it did not show any transillumination. Now, transillumination basically means that there's a swelling, we put the torch on one side, turn it on, and we see from this side, if you see the light coming, that is called transillumination. So for hydroceles or for cysts or any place which has got fluid in it, you get transillumination. Solid mass obviously would block the light, and you would not see any transillumination. So it's basically to differentiate between cysts and solids. So there was no transillumination. So which means this is something which is there, which has been stuck, and it is not cyst. Okay, it was very tender and had some increased temperature on the surface, which would tell you that there is some inflammation going on. Ultrasound was performed, and on the basis of this ultrasound, the sonographer told something to the ED doctor, and they immediately took her to surgery. So this is something which was very urgent, and the diagnosis is not just something which you would take lightly. Okay, so this is something with which, as a sonographer, you have a very major role to play to guide the ED doctor and potentially save something about this little girl, which would become apparent maybe 20 years later. Okay, so think about that. You can discuss these cases in discussion groups. Initially, there was some problem with the discussion groups. I don't know what happened, but I corrected that. So now you should have access to the discussion groups. Put them up. There are these ultrasound images with some arrows pointing to some things in the right groin, especially this image and this image. This is what surgery showed, and this is what histopathology showed. Okay, so think about that, and I will reveal the diagnosis on Friday. And probably all of you are really smart, and you can do that. All right, any questions at all you might have? Sorry, it got a lot clinical, but I was, I've been at this university for 4 years, and I started this Masters of Medical Ultrasound course, and I was the head of course for this whole thing, and I have made it clinically relevant. Michelle has done excellent job in putting up very clinical material, because when I started this masters, there are other masters by other universities as well. But my concept was that I totally agree and acknowledge that you guys are experienced sonographers. There is not much sonography that I can teach you. Yes, there are new techniques, there are new machines, elastography, contrast enhanced ultrasound, all those kind of things are there. But there's not much I can teach you. Maybe you can teach me ultrasound a lot better than I know, because some of you have been in practice for decades. But what can this masters then add is the clinical knowledge, is the clinical thinking, and fine-tuning your sort of mind towards looking beyond the image that I say. So I don't know how much we have succeeded in that, doing that, but you will appreciate that this course is so different from all the other sonography courses that you would have taken up till now. I am leaving the university, and I hope that this master's program would continue and would in fact flourish. New blood will come in, new ideas will come in, which is always better than one person controlling everything. So yeah. Anyway, thank you very much. It was short but very nice to have interacted with you guys, and I'll be going back into clinical, working as a radiologist down south, but I will still be doing ultrasounds also. So you're welcome. If anybody is in or around Sydney or Central Coast, maybe you will see me somewhere sitting in a little dark room in front of a TV monitor. Okay. Everybody, thank you very much. If you have anything, you can ask me, or you can ask me in the where is the chat? Oh yeah. Okay. Thank you and thank you. Okay. Thank you very much, and have a good night.
Thank you. Bye.
Bye.